welcome to my channel. Okay, so we are starting the urology unit. We are having the topic renal trauma. So there is a scenario that says that there is a 48 hours blunt abdominal trauma history of 15 years old boy with hematuria and pain in left lumbar region. On examination, pulse is 96 per minute and BP is 110 by 70. Abdomen is centered in left lumbar region and there is no palpable mass. HB is 10.7 gram. So what is the diagnosis and what is the management? Now we are having 10 kidney trauma, that is 10 blunt, and 90 is RTA, road traffic accident. The staging of the trauma is graded on CT scan findings. The grade 1 is contusion and contain no laceration. The grade 2 is laceration and that is less than 1 centimeter. The grade 3 are laceration that are greater than 1 centimeter, and the grade 4 are injury involving collecting system. Grade 5 is stage kidney or hilum avulsion. Okay, now also the grade 1 is subcapsular hematoma, grade 2 is cortical laceration, no communication with pelvis. No communication with pelvis. Grade 3 is perirenal laceration, that is one greater than 1 centimeter deep. Grade 4 is cortical laceration, extend to pelvis, and grade 4 is shattered kidney. So this is the grading of the renal trauma or kidney trauma. Now what are the clinical features? These are: there is history of trauma, hematuria, flank pain, and bruising. What investigations we will do? These are ultrasonography, that is subcapsular or retroperitoneal hematoma, then contrast enhanced helical CT scan for injuries and grading of renal trauma performed only in hemodynamically stable patient. Then one shot IVU intravenous urogram, that is in stable patient, single X-ray KUB taken after injecting urographin. How we will manage the renal trauma? We have to measure a broad classification, that is for hemodynamically stable patient and the management for hemodynamically unstable patient. So for hemodynamically stable patient, we have time. So first we will investigate the patient, then renal imaging CT scan and IVU is done, and then surgical exploration if persistent gross hematuria is present. For hemodynamically unstable patient rushed to the OT. Partial or total nephrectomy to control bleeding is done, and on table IVU to confirm renal injury. Now conservative measurements are done, that is admission to the ward, strict bed rest, record vitals frequently, analgesias, fluids, cross-match blood and transfuse if necessary, prophylactic antibiotics are given, urine output is measured, and examination is done daily. The surgical management are: the indications are persistent severe bleeding or shocking, expanding or pulsatile retroperitoneal hematoma, associated injuries to other abdominal organs, that is bowel, liver, spleen, and pancreas. The surgeries are midline laparotomy, explored both kidneys and abdominal viscera for injury. One shot IVU for both kidneys, explored hematoma, repair renal injury, and nephrectomy if severe injury is present. The surgical options are for small tear sutures, the sutures for small tear, and partial or complete nephrectomy for grade 3 and grade 4 injuries, and repair, that is mesh repair for the damage of solitary kidneys. So what we have discussed? We have discussed the renal trauma, then the scenario for the renal trauma, then what is the staging of the renal trauma, the grading of the renal trauma on basis of different factors, then the clinical features, then the investigations that are done, that is ultrasonography, contrast enhanced helical CT scan, and one short IVU is done, then the management for hemodynamically stable and unstable patient, then the conservative management, then the surgical management, then the indications for the surgical management and which surgeries can be done. The surgical options, that is sutures, partial or complete nephrectomy, and repair or mesh repair. Now coming towards renal stones. There are types of renal stones. These are calcium oxalate, which is at a 5%, steroid, that is 2 to 20%, phosphate 10%, and uric acid is 5 to 10%. Cysteine and xanthine stones are rare. The clinical features are asymptomatic uremia, pain, hematuria, pyuria, that is infection. The investigations that are done for renal stones are X-ray KUB, ultrasound, intravenous urogram, and CT scan. The treatment options are: first you have to observe the patient. If it is less than 5 mm, analgesia, antibiotics, and plenty of fluids are given. Medical expulsion therapy is given for 6 to 8 mm, and leucine plus analgesics plus antibiotics are given. Extracorporeal shockwave lithotripsy is done. The indications for extracorporeal shockwave lithotripsy is when the stones are greater than less than 2 cm, when the stones are greater than 2 cm but located in the lower pole, or ureteric size is less than 1 centimeter. The contraindications are pregnancy and UTI and urinary tract obstructions. The percutaneous nephrolithotomy is done for less than 2 centimeter, that is 90% clearance, and greater than 2 centimeter for 80% clearance. Indications are Stanghorn calculi if it is larger than greater than 2.5 centimeter, and if the extracorporeal shockwave lithotripsy failed. Then the retrograde intrarenal surgery is done, and then the open surgery is done. The open surgery is for large and complex stone and for obese patient. Pyelolithotomy, extended pyelolithotomy, and anatrophic nephrolithotomy are the surgical procedures. So we have discussed the renal stones, its types. There are 5 basic types, then the clinical features, then investigations that are done for renal stones, then the treatment option, that is observation is done, medical expulsion therapy is provided, extracorporeal shock wave lithotripsy is done, and the indications and contraindications are, then the percutaneous nephrolithotomy is done, and retrograde intrarenal surgery is done, and then the open surgery is done. Now coming towards the renal tumors, there are benign renal tumors and malignant renal tumors. The benign are adenoma, angioma, angiomyolipoma. The malignant are Wilms tumor, also known as nephroblastoma in children, Growth's tumor, that is adenocarcinoma, hypernephroma, then the transitional, the cell carcinoma, then the squamous cell carcinoma. Now coming towards the Wills tumor, that is nephroblastoma. It is pediatric before age of 5 years. The clinical features are abdominal mass in 90%, flank pain 30%, hematuria 50%, hypertension 50%, metastasis in lung 92%, in liver is 18%. The investigations that are done for the nephroblastoma are ultrasound and contrast enhanced CT scan of abdomen and chest. The staging of Wilms tumor are stage 1, that is confined to kidney and completely excised. Stage 2 is unilateral tumor not excised completely. Stage 3 is tumor crossing midline, and stage 4 is metastatic disease. The treatment options are radical nephrectomy followed by chemotherapy, then chemotherapy, that is actinomycin D and doxorubicin, then partial nephrectomy, and then overall good prognosis. Okay, so we have discussed the Wilms tumor, its clinical feature, investigation, staging, and treatment. Now coming towards the renal cell carcinoma, also known as Gravet's tumor. The scenario are complaint. There is a complaint of left loin pain and hematuria for 2 months. Ultrasound shows large central mass in left kidney. On examination, no except varicocele in left scrotum. So what are the investigation? What are the types of tumors? Why patient have varicocele? What are the treatment options? What are the causes of hematuria? The management and the differential diagnosis. Another scenario is that there is clots in the urine and no pain. Another scenario is weight loss and pain, and another scenario is firm mass palpable. So renal cell carcinoma is the most common tumor of the kidney, arise from proximal convoluted tubule. The risk factors are smoking, renal failure, hemodialysis, polycystic kidney disease, exposure to asbestos, and VHL syndrome, that is von Hippel-Lindner syndrome. Bilateral renal cell carcinoma, pheochromocytoma, pancreatic cyst. Then the spread is direct extension. The renal vein may extend to and the renal vein and the renal vein may extend to inferior vena cava and lungs and bones, hilar and para-aortic lymph nodes. The clinical features are hematuria, that is 50%, dragging flank pain, that is 40%, palpable kidney mass, that is 30%, and left side varicocele. Atypical features are bony pain, hemoptysis or cough, persistent pyrexia, hypertension, and polycythemia. The investigations that are done for renal carcinoma are urine examination, that is hematuria is present, ultrasonography with that is gold standard for staging. Okay, ultrasonography with power Doppler. So this is the gold standard for the staging of renal tumor, and it protect involvement of the renal vein, lymph node, and metastasis. The MRI is exact involvement of the tumor. X-ray, chest or CT scan shows metastasis, and bones case for bony metastasis. Now the TNM classification of the renal cell carcinoma, we are having it T for tumor, R, N for lymph nodes, and M for distant metastasis. To note that there is no evidence of tumor. T1 is tumor less than 7 cm in greatest dimension limited to kidney. The T1A is tumor less than 4 cm in greatest dimension limited to kidney. T1B is tumor greater than 4 cm but less than 7 cm in greatest dimension limited to the kidney. T2 is tumor greater than 7 cm in greatest dimension limited to the kidney. T2 is tumor greater than 7 cm but less than 10 cm in greatest dimension. T2B is tumor greater than 10 cm in greatest dimension limited to kidney. Okay. So T1A, T1B, T2B, T2, that is T3, T3A, T3B, T3C, and T4. These are the tumor classification. The T4 is tumor invades beyond Gerota's fascia or adrenal gland. The N0 and N1 and N2 are present, and the distant metastases are M1 and M0 and M1. Okay, now the treatment options for renal cell carcinoma are primary surgical treatment, that is European Association of Urology. For T1A nephron spacing surgery or partial nephrectomy is done. For T2B radical nephrectomy is done. For T2 radical nephrectomy and for T3 radical nephrectomy is done. The treatment options for localized renal cell carcinoma, that is T1, T2 and T3A, are standard radical nephrectomy, mass excision of the kidney, adrenal gland, Gerota's fascias with para-aortic lymph nodes along with proximal ureter. Now laparoscopic nephrectomy is done for stage 1 tumor that is less than 7 cm. Partial nephrectomy is done for nephron spacing. For bilateral tumor, for example, or tumor in solitary kidney for less than 4 cm tumor. T3B, T3C is done for the involved, so it is claimed. T4 is done for radical nephrectomy for poor prognosis. The radiotherapy is the palliative bone and spinal cord metastasis, and immunotherapy is done for the interleukin 2, interferon alpha, interleukin 2, and toxicity limits is used. Okay, so we have discussed the renal cell carcinoma, which is the most common tumor of the kidney that arises from the proximal convoluted tubule. Then we discuss its risk factors, then the spread, then what is the clinical features and what are the atypical features, then the investigations options, which are urine examination, ultrasonography, MRI, X-ray chest, and bone scan. Ultrasonography is the standard. TNM classification, that is the tumor, regional lymph node and distant metastasis. Then the treatment option, that is primary surgical treatment, and then for T1A, T1B and T2 for the different classes of the tumor. Then the treatment options for localized renal cell carcinoma, then laparoscopic nephrectomy, in which cases partial nephrectomy, in which cases then the radiotherapy, and then the immunotherapy. Now coming towards the urinary retention. We are having a scenario that there is a 70-year-old male present with acute retention of urine. What are the differential diagnosis, the diagnosis and the management? So the definition and the types are acute retention and chronic retention. Definition is unable to empty bladder, differentiated from anuria. Okay, in acute retention, that is in male, bladder outlet obstruction may be present, urethral stricture, carcinoma prostate, bladder outlet or obstruction is present, and post-operative retention of urine can occur. In female, uterine prolapse can occur, cystocele and bladder neck stenosis may present. In children, meatal stenosis may present, and in both in general hematuria, impacted bladder or urethral stone, urethral injury, neurogenic, fecal impaction following groin and perineal surgery, and spinal anesthesia. The clinical feature for acute retention is failure of the passage of urine for some hours and pain, palpable tender bladder, dull percussion note or bladder. In the chronic retention, the causes are BPH, which is most common, that is painless suprapubic dullness, slow decompression is recommended. Bladder neck contracture may present, strictures of urethra may present. The clinical features are pain, failure of the passage of urine, palpable and tender bladder, dullness on percussion note, and over bladder. The differential diagnoses are BPH, prostate, cystitis, urethritis, and vulvogenitis. Now, the treatment options for acute retention are that is catheter, therefore 14 or 16 two-way Foley catheter with adequate hydration, lubrication under strict aseptic conditions. Cystostomy if catheterization fails, or suprapubic cystostomy is done. For chronic urinary retention at birth, apply plastic film to cover bladder defect, pelvic osteotomy, closure of the bladder and abdomen. For 1 year, epispedia repair. For 5 year, bladder reconstruction and anti-reflux surgery is done. Okay, so we have studied the urinary retention, the scenario, then the definition. Then there are two broad classes, the acute and the chronic retention, and the causes of acute and chronic retention in male, female, in children, and in both. And then we discuss the clinical features. Then we discuss the treatment options for both the acute and the chronic urinary retention. Now coming towards ureteric stone, we are having a scenario that there is a 25 years old patient with dysuria and pain on X-ray KUB, opacity in pelvis in line of right ureter. So another scenario is that there is severe left side abdominal pain, radiates to groin, unable to keep still, vomited 5 times a bowel, normal, no rectal bleed. On examination, BP pulse is normal, and tenderness in left loin. Rest of abdomen normal. Urine analysis shows RBCs. The diagnosis, mastication, treatment and complications and management. Okay, pass spontaneously, arrest in PUG consisting of iliac vessels, crossing of vasa entrance in bladder wall and uterine opening. Okay, these are the uteric stone clinical features, that is pain is dull, flank ache, colicky pain, strangury, painful passage of the few drops, and hematuria, that is microscopic. The investigations options are ultrasonography, X-ray, KUB, intravenous urogram, and non-contrast enhanced CT scan. The treatment options are 90% stones less than 5 millimeter pass spontaneously. If not pass, then require endoscopic treatment. Surgical intervention which not pass spontaneously, then surgical interventions are done for those. Okay, the proximal uterine stone is less than 10 mm. For it, extracorporeal shockwave lithotripsy is done. For proximal uterine stone greater than 10 mm, so this procedure is provided, and for distal uterine stone less than 10 mm, then these procedures, and the distal uterine stone greater than 10 mm, then these procedures. Okay, the options are uterine stone treatment. That is endoscopes which enter the bladder through urethra and enter urethra. The double J stents. The stents are used, then plastic tubes inserted over guide wires via cystoscopy through bladder into the ureter. Then push bang stones pushed into kidneys and treated by extracorporeal lithotripsy. Dormia basket is used. Open surgery is done. Stones in upper third through pylolithotomy incision, and stones in distal end of the ureter are removed by Gibson's incision. Stones at middle third ureter are removed by muscle cutting iliac fossa incision. Okay. So we have discussed the uterine stone, the scenario, the clinical features, investigation, the treatment options. That is uterine scope stone treatment, JJ stents, pushback treatment, Dormia basket, and open surgery. Now coming towards the bladder cancer, we are having a scenario that there is a 55-year-old smoker, painless hematuria. 5 episodes of hematuria are present, which last for 4 to 5 days in past 1 year. The passage of small blood clots in urine, cystoscopy revealed bladder tumor. What are the differential diagnoses of painless hematuria, investigation and staging of bladder cancer, and treatment for urinary bladder carcinoma? Another scenario is that there is second commonest urological cancer and affects people in 6 and 7 decades of life. The pathology is that the transitional cell carcinoma is 90%, the squamous cell carcinoma 5% associated with chronic inflammation of the bladder. Adenocarcinoma is 2% arise from remnant in the bladder. What are the causes? Exposure to the aniline dye, smoking increase risks up to 5-fold, drugs that is phenacetin and cyclophosphamide, carcinogenic compounds that is benzodiazine and tolvidine and its derivatives, and the occupations associated with increased risk: rubber industry, textile workers, dye workers, tire tube and cable workers. Now the clinical features are increased age, painless gross hematuria, irritative lower urinary tract symptoms, advanced bladder cancer, that is hydronephrosis and renal failure and cachexia. These are the clinical features. Now the investigations are urine examination for hematuria, urine cytology, mid-morning urine is collected and centrifuged and examined for malignant cells, and ultrasonography is done for bladder growth and hydronephrosis, intravenous urogram, filling defect in bladder, hydronephrosis if present, and cystoscopy. Now the staging of TNM, that is T, regional lymph nodes and distant metastasis. Okay, so there are T node, T8, T1, T2, T3, T3A, T3B, T4B. The N is N node, N1, N2, and N3, and M node, M1. Okay, these are the staging for the tumor classification or TNM staging. Then we are coming toward the treatment, that is carcinoma not involving muscle layer. What is the treatment option for the carcinoma that is not involving the muscle layer? That is TS, TA, and T1. So transurethral resection is done for the tumor. Post-operative intravesical chemotherapy with thiotepa, adrimycin, or mitomycin retained inside the bladder for 1 hour. It reduces recurrence. Then the T2 for T4 lesions, radical cystectomy is done, followed by systemic chemotherapy, that is methotrexate, vinblastine, cisplatin, and adrimycin. Any T1 and M node or any T and not M1, systemic chemotherapy is done, followed by radiation therapy, and for small lesions involving mass in the posterior wall of the bladder, so partial cystectomy is done. So we have discussed the bladder cancer, the scenario for it, that is then the pathology of the bladder cancer, then what are the different causes, what are the clinical features, and what are the investigations options. The investigations options are urine examination, urine cytology, ultrasonography, and intravenous urogram, then the cystoscopy. Then we did the TNM staging, and then the treatment options for the different stages. That is the carcinoma not involving mesothelioma, then what will be the treatment option for T2 and T4 lesions, for any T and 1 M node or any T and not in M1, and for small lesions the treatment options. Now coming towards the benign prostatic hyperplasia. We are having a scenario that there is a 81-year-old man difficulty in passing urine. He repairs decreased urinary stream with increased nocturia. On examination of abdomen, palpable suprapubic mass, which is not tender and dull to percussion. RBE revealed enlarged smooth filling prostate gland. So the diagnosis, management, and features of DRE leading to prostate cancer. The common benign condition, the benign prostatic hyperplasia is a common benign condition, and its causes are BPH is testosterone dependent tumor. Testosterone is produced by leading cells of testes under influence of luteinizing hormone, which itself are secreted by anti-pituitary and hypothalamus. Testosterone 5 reductase 5 dihydrotestosterone. So increase 5 alpha reductase, then increase concentration of DH, and thus there will be enlargement of the prostate. Benign prostatic hyperplasia affects transitional zone of the prostate and compress the urethra. The clinical features are irritative symptoms and obstructive symptoms. The irritative symptoms are dysuria, frequency, nocturia, urgency, and urge to incontinence. The obstructive clinical features are poor stream, hesitancy, intermittent stream, incomplete emptying, and post dribbling and retention of the urine. The investigation option for BPH are history, that is IPSS, International Prostate Symptom Score, then abdominal and digital rectal examination. Abdominal examination reveal distended bladder in chronic retention, and on DRE prostate can be assessed for size and features of the malignancy. Then blood tests are done for urea, creatinine, and electrolytes. Urine tests are done for glucose, RBCs, and pus cells. Ultrasonography to assess the size and weight of the prostate. Prostate specific antigen, urodynamic study, cystourethropy, and uroflowmetry. In cystourethropy, person is asked to void urine from his full bladder with fluorometer. Flow rate is assessed. Then normal peak flow rate is 20 ml per second. So doubtful peak obstruction is 10 to 15 ml per second. Definite peak obstruction is less than 10 ml per second. Thus, the degree of the bladder outlet obstruction can be secured by uroflowmetry in case of BPH. The treatment options are watchful waiting, medical treatment, and surgical treatment. In watchful waiting, mild symptoms, decrease fluid intake at bedtime, decrease alcohol, and decrease caffeine. These are the treatment options. Then for medical treatment, alpha blockers and 5 alpha reductase are given. Alpha blockers are doxazine, terazosin, relax smooth muscles in prostate and bladder neck, and rapidly relieve symptoms, given with moderate size prostate. Then 5 alpha reductase is given. Inhibit conversion of testosterone to more potent 5 dihydrotestosterone. These drugs decrease the size of prostate. Then surgical treatment is provided. The surgical treatment indications are when medical treatment fails, there is recurrent acute retention, renal failure, and chronic retention, hemorrhage, and patient choice. If the patient's choice is surgery, then we will go for it. Okay, so the surgical options are prostatectomy and the transurethral resection of the prostate, which is gold standard cystourethropy. Then transverical prostatectomy, and then the treatments are TUNA, TUMT, TUEVP, and HOLEP. These are the nerves treatment. The complications of treatment are hemorrhage, incontinence of the urine due to sphincter damage, sepsis, retrograde ejaculation, bladder neck structure, and recurrence of the BPH can occur after 10 to 15 years. Okay, so we have studied the benign prostatic hyperplasia, then the scenario, then the etiology or causes, then the clinical features, then the clinical features, the main classes, these are irritative and obstructive. Then the investigation options, that is history taking, abdominal digital rectal examination, blood test, urine test, ultrasonography, prostate specific antigen, urodynamic study, cystourethropy, and uroflowmetry is done. Then the treatment options are watchful waiting, medical treatment, and surgical treatment. Now then we discuss the complications. Now coming towards the carcinoma prostate, there is a scenario that there is a 70-year-old patient, increased frequency, maturation, dribbling, and poor stream for last couple of years. Symptoms have got worse in last 3 months. Dribbling of urine very frequently, incontinence at time. Okay, need large smooth painless swelling which reach to just above umbilicus, or prostate was irregularly. Okay, so what are the diagnoses, the causes of urine retention, and what are the treatment of patients with carcinoma? Carcinoma prostate, most common malignant tumor of the men over age of 65 years. The risk factors are age, race, that is common in blacks, diet, increased pregnancy, and positive family history. The pathology is that adenocarcinoma is occur in 95% of cases. The spread is through local extension, blood lymph nodes, local spread, hematogenous spread, and lymphatic spread. The staging is for tumor for okay. Now coming towards the clinical features. Localized T1 and T2, locally advanced T3 and T4, and metastatic disease. So what are the clinical features for localized T1 and T2? It is asymptomatic, LQTS, and hematuria may occur. Locally advanced T3, hematuria, deep perianal pain, renal failure due to bilateral uteric obstruction in metastatic disease, bony pain, spinal cord vertebral collapse, compression, anuria, pain, cytopenia, cough and hemoptysis, and liver function. Okay, the investigation options for DRE, that is dystolic examination for prostate, nodular, hard and crazy. For prostatic specific antigen greater than 10 mg per ml, cancer for greater than 20 nanogram per ml, and for advanced prostatic cancer, the transurethral ultrasonography and biopsy, MRI and CT scan, bone scan radiography, that is HRCT for metastasis in lung and ribs, and liver function test. The treatment options are for early malignancy and late malignancy. If the tumor is localized T1A disease, then watchful wait and PSA for 3 to 6 months, that is prostate specific antigen is given. For T1B, T1C, and T2, radical retropubic prostatectomy or radical radiotherapy is done. Radical prostatectomy is done for T1 and T2. Removal of all prostate seminal vesicles and surrounding tissues via open surgery, laparoscopy, or robot assisted. Radical radiotherapy is done. It provides good results and is less complicated. For late malignancy, T3 lesions, involvement of the recent lymph nodes or pressure of metastasis, androgen ablation, T3, T4 of metastatic disease, low orchidectomy, drugs and medical castration. Then the radiotherapy is done for multiple metastasis. Palliative treatment is done for local radiotherapy, chemotherapy, drugs, mitomycin, and doxorubicin. In summary, T1 is for surveillance, T1B, T1C, and T2 is radical prostatectomy or radical radiotherapy for age less than 70 years, and T3, T4 hormonal ablation is done. Okay, the treatment is providing according to the TNM classification. So we have discussed the carcinoma prostate, the scenario, then the definition, then what are the risk factors, then the pathology, then the spread, then the staging, then the clinical features, then what are the investigations. These are DRE, prostatic specific antigens, transrectal ultrasonography and biopsy, then MRI and CT scan, then bone scan, then radiotherapy, and then the liver function test. Then we discuss the treatment options for early malignancy and late malignancy, for localized T1 disease, T1B, T1C, and T2, and radical prostatectomy, radical radiotherapy, and late malignancy, then the radiotherapy, palliative treatment. In summary, then we discuss this in summary for the case of benign prostatic, for the case of carcinoma of prostate. Okay, now coming towards the crypto or autism. Undescended testes. The scenario is that there is a 5-year-old child complain of only one testis in scrotum. On examination, testis on left side is felt in inguinal canal. So define undescended ectopic testis, then different locations for undescended testis and the complications and the treatment. So the definition is that it is a condition in which testis fails to descend into scrotum. There is 40-fold increase risk of malignancy. The incident is birth is 40% and 80% is scrotum in first 3 months. Okay, the types are absent, retractile, incompletely descended, and ectopic testes. Retractile or scrotum well developed testes can brought down by traction. Incompletely descended testes are descent assisted anywhere from abdomen to inguinal canal to superficial ring. And ectopic descendant testes are testes the inguinal ring goes to the superficial inguinal pouch and perineum and thigh. The clinical features are right side affected more, that is 20% bilateral. The complications are sterility, the bilateral case, hernia, torsion, trauma, increased risk of malignancy, and atrophy. The investigation options are laparoscopy, or this is the investigation of choice, and ultrasonography. The treatment options are orchidopexy, that is perforated edge of 1 ear. In bilateral cases, only one side operated at one time. Then Fowler procedure if testis can't bring down through orchidopexy. Difference between ectopic and undescended testes. This is undescended testes, this is ectopic testes. Okay, undescended testes do not reach the scrotum, but it is present in its form of descent, path of descent, and ectopic testes adopt wrong path. These include superficial inguinal path, perineum, femoral triangle, and root of the pelvis. The different locations for undescended testes are abdomen and inguinal canal. Okay, so we have discussed the undescended testes, that is cryptorchidism, and the scenario, the definition, the types, then the clinical features and the complications, then investigation, then the treatment option. There is orchidopexy and Fowler procedure. The difference between ectopic and undescended testes, the undescended testes and ectopic testes, at different locations for the undescended testes. Now coming towards the torsion of testes. A scenario that there is a 15 years old boy present with acute scrotum. Discuss management. So the definition is the twisting of spermatic cord resulting in strangulation of blood supply to testes, that is testicular artery. It mostly occurs in teenagers 13 to 15 years. The causes are high investment of tunicle vaginalis, clyperbel deformity, minor injury to the testes, and coitus while sleeping. The strains and the lifting heavy weights. The clinical features are age 10 to 15 years and the strain, that is lifting heavy weights and coitus. The differential diagnosis are torsion of testes and epididymoorchitis. In torsion of testes occur in younger patient 10 to 15 years. Pain is increased by elevation of testes and there is no dysuria. In epididymoorchitis occurs in older age, that is 20 to 35 years. Pain is relieved by elevation of testes. Dysuria may be present. The investigation options are clinical Doppler ultrasound and scrotal ultrasound. The treatment options options are conservative treatment, that is dental manipulation to untwist the testes may be attempted in first or also. The surgical treatment options are counsel the patient's consent for architectomy. Exploration is performed through scrotal incision. Inspect the testes. If they are viable, then fixation is done by non-absorbable sutures between tunica vaginalis and tunica albuginea. Along with that, check opposite testes and also fix them between the anatomical variation predispose the torsions in other testes as well. If testis is not viable, then orchidectomy is done. The complications are infertility, tumor of the testicular, cosmetic problems, and damage or death of the testicles. So we have discussed the torsion of testes, the definition, the causes, the clinical features, and the differential diagnosis of the torsion of testes and epididymoorchitis and investigations options. Then the treatment options, which are conservative treatment and surgical treatment, then the complications. Now coming towards the varicocele, we are having a scenario that there is 37-year-old swelling in right scrotum for 2 months, no history of trauma. On examination, can get above swelling and epididymis is separately palpable and normal trans illumination test is negative. So what are the diagnosis, the differential diagnosis, investigation, and the treatment options? The definition is the dilatation of the pampiniform venous plexus that runs with spermatic cord, and the causes are the common on the left side is left testicular vein form or angle of the 90-degree with left renal vein, then congenital absence of the valves, left renal carcinoma may obstruct left testicular vein causing its dilatation. The clinical features are dragging discomfort, scroting of the affected side hangs lower than normal, and on palpation varicocele feels like a bag of worm. The different grades are grade 1, grade 2, and grade 3. Grade 1 is palpable after Valsalva maneuver, grade 2 is palpable after standing position, and grade 3 is visible. The investigation options are ultrasound of the scrotum, then semen analysis. The treatment options are asymptomatic, require no treatment, then the surgery is done indicated in scrotal pain infertility as part of requirement in normal armed forces, laparoscopic varicocele repair, then open ligation of the testicular vein and the embolization of the testicular vein under radiological guidance in procedure of the choice if facilities are available. Inguinal approach, retroperitoneal approach, and sublingual microscopic approach is done. So we have discussed the varicocele, then the scenario, the definition, the causes, the clinical features, and the 3 grades, then the investigations options, and then the treatment options, which are for asymptomatic, then the surgery, laparoscopic, open ligation, embolization, then the 3 approaches, the inguinal approach, retroperitoneal approach, and sublingual microscopic approach. Coming towards epididymoorchitis, it is inflammation of the epididymis and the testes. The causes are UTI, instrumentation, catheterization, sexually transmitted, and viral mumps, that is 18%. The clinical features are symptoms of UTI, pain in groin, painful lead, epididymis orchitis, edematous scrotal skin. The treatment options are scrotal support, antibiotics, ciprofloxacin, analgesics, and scrotal abscess may form which needs incision and drainage. Now coming towards the testicular tumor, we are having the scenario that there is a 31-year-old male lump in the right testis is present, dragging pain while walking. On examination, 3 cm palpable lump is felt on inferior aspect of the right testis. Rest of the testis and epididymis can be felt separately. Mass does not transluminate. Mass not tender on palpation. Another scenario is that there is 30-year-old dull pain in right hemiscrotum and swelling of right testis for 4 months. Swelling increased in size for the last 1 month. Hemoptysis for 2 weeks is present. So what is the diagnosis? Differentiate between different scrotal swelling, then classify tumor of the testis, the treatment options, the investigation, the management, and the DDs. The differential diagnosis for the testicular tumor is that it is acute and chronic epididymoorchitis, old clotted hematocele, or seminal granuloma. The definition is that it affects young men 20 to 40 years of age. Present is a painless unilateral mass in scrotum. Majority of testicular tumor are malignant. Most are curable. The causes are undescended testes, increase 40-fold, Kliefeld syndrome, positive family history, and infertility. The classification of testicular tumor is that it is germ cell tumors, which is 90%, sex cord, gonadal stromal tumors 3%, and miscellaneous non-specific stromal tumors. These are seminoma 48% and non-seminoma GLT 42%. Then the sex cord stromal tumors are Leydig cell tumor and Sertoli cell tumors, thecoma or fibroma tumor, and other sex cord or gonadal tumor. The miscellaneous non-specific stromal tumors are epithelial tumor, and then the tumors of the collecting ducts and testes, then the tumors benign and malignant of non-specific trauma. The clinical features are painless and form to heart. Irregular scrotal mass may replace testes. 10% patients present after minor trauma, and secondary legs hydrocele may be present. Para-aortic lymph nodes may be palpable. Epigastrium may be for hemoptysis due to pulmonary metastasis and gynecomastia, and 10% of the cases is present. The investigation options are physical examination, that is scrotal examination, and lymph nodes. The ultrasound, that is first investigation, can differentiate tumors from other cystic swellings of this axis. In the contrast, in HCT, abdomen and chest for staging, and the tumor markers that measure 2 weeks after surgery, and then on to the gauge remission and recurrence. The tumor markers are alpha fetoprotein, that is raised in 50 to 70% of the teratoma and yolk sac, the beta HCG, the lactate dehydrogenase, the placental alkaline phosphatase. Then the biopsy is done. The TNM staging is present here, that is TX, T0, TIS, and T1 and T2, T3, T4, TB, and for metastasis M0, M1A, and M1B, for lymph nodes N0, N1, N2, and N3. The treatment options are radical orchidectomy, that is carried out through inguinal approach. Then the organ sparing surgery is attempted in the special cases, and testicular prosthesis after surgery for cosmesis is done. Post orchidectomy management is surveillance, that is regular follow-ups, measurement of the tumor markers, repeated CT scans, and patient relapsing when the surveillance is given. Chemotherapy is provided, it is bleomycin, etoposide, and cisplatin. Okay, so we have discussed the testicular tumor, the scenario, then the diagnosis, differential diagnosis, the definition and the causes, and the classification, then the clinical features and the investigation options, and then the TNM staging and the treatment options. This was the last unit of the systemic surgery. In our next video, we will start the medicine subject, and we will discuss each unit per day. Thanks for watching.